In the next few slides, we're going to talk about some sympathomimetic agents that are not adrenergic agents. First one, and the most famous one, is vasopressin. You'll probably have used it in the ICU. And as you know, the target sites for ADH are the renal collecting ducts, vascular smooth muscle, and cardiac myocytes. When ADH binds to these receptors, we get passive reabsorption of water from renal collecting ducts into the extracellular fluids. In addition to renal action, we also get the intense vasoconstriction and a little bit of inotropism, not clinically significant, but at least in situ we get inotropism with it. When you compare vaso to epinephrine, vasopressin causes a larger increase in systemic vascular resistance, cerebral perfusion pressure, and coronary perfusion pressure. Epi does not work well in acidic environment, so it makes vasopressin a more effective vasoconstrictor in the presence of hypoxia and acidosis. In contrast to epinephrine, vasopressin doesn't seem to increase the mixed venous oxygen saturation or lactate production. What about adenosine? It's an endogenous nucleotide, and you get increased production of adenosine with hypoxia and ischemia. So in a stress tissue, be it the cardiac muscle, skeletal muscle, it usually works as a local mediator in skeletal muscle in particular, and cardiac for perfusion to the heart. When you have adenosine receptor binding adenosine and it gets activated, you get an increase in the outward potassium current, so the cells become hyperpolarized. This means in conduction system we get slowing or stopping the action potential, and in vascular smooth muscle we get dilation of the vessels that are supplying that specific muscular bed. In conduction system, when adenosine binds to the receptor, we get slowing of the conduction. It affects both the SA node slowing and AV nodal conduction delay. In the atrial myocyte, it causes hyperpolarization, so we get decrease in the action potential duration via an increase in the outward potassium current. And as you know, the half-life of adenosine is extremely short. That's why you give 6 milligrams when you want to stop the heart for a short period of time. Now, phosphodiesterase inhibitor are the ionotropes and vasodilators that are completely independent of adrenergic system. They selectively inhibit phosphodiesterase 3, and PDE3 decreases the breakdown of CAMP, so we get more ionotropism in cardiac myocytes. In vascular smooth muscles, increase in CAMP activity accounts for the vasodilation, decreased peripheral vascular resistance, and lusitropism. That lecture, somebody's going to define what lusitropy is for me.